Good morning, and thanks again also for the invitation. And because I'm based in Barcelona, I was more kind to come to London to change a bit the surrounding. No? I think this introduction was great, Rosanna, because it's really putting the core of discussion of where we are, where we go, and how we tackle. And I'm not starting with the end of my presentation. I'm just going back to 1 year before and the conclusion I made on the session on diagnostic to say that, yes, we have to acknowledge that there is some progress in terms of diagnostic, especially for Kala-Azar and HIT and Chagas, but still a lot to be done. Algorithms must be adapted. We have to consider also the external factors when developing global strategy of diagnostic, and the access of patient to diagnostic is as important as the performance of the test or the technology used. And then, if I summarize more MSF messages around, let's say, the past 10 years, and try to see what has been done in terms of progress, especially for the disease we are working most in, which is HIT, Kala-Azar, and Chagas, I just find that, okay, there are some progress. RDTs are developed for HIT, which is good, but it's still very, very slow, and so far we haven't got any modification of the generic algorithm. In Kala-Azar, as mentioned, ERK39 is and will be for the following 5 or 10 years the only test we have. And there are some problems of performance, and not only performance. I mean, the example of Sudan, because it's an American-based company, the ITLH, the most performant one, and they signed the ban of importation and commercial agreements between Sudan and US, then the Ministry of Health and the Kala-Azar control program is not allowed and cannot have access to the ITLH, ERK39, meaning what they are using is the InBIOS, which actually is very, very low sensitivity. So it's a never-ending story. And still in Kala-Azar, no progress was done on test of cure, and PKDL diagnostic is also a big issue. The only one that's moved a bit forward, but also it's tackling Latin America, so it's having its impact in terms of how fast development of technology can go sometimes for specific area, but still test of cure is not. We still have this big discussion on what is the best biomarker of cure. So more than 10 years, no progress. The only one is algorithm based on RDT. It's almost done. There are more and more evidence. We have made this huge study on evaluating what was commercialized, and at the end, now popping up a lot of publication saying that a combination of diagnostic is good, sensitive enough. So this is the only one where we can say, yes, we have been progressing in the past 10 years. And there are also new challenges. I'm just putting the most terrific context, but South Sudan example. South Sudan was quiet or considered as a stable country, but in the past 2 years, the situation is becoming more and more critical. There are a lot of movement of population. Health facilities are targeting by bombing, destroy in the conflict. And then what is important in South Sudan is that at the end, it reflects that we all work on mapping, and it was well known that this area was more sleeping sickness area. The other one was more Kala-Azar, and then you had Schisto on one side, and then you have, but with all the movement and all this conflict, what is happening now, it's a completely destructuration of the well-known map of where the disease, and on the top of this, you have more and more co-infection, because people moving with African trypanosomiasis get Kala-Azar, in the meantime they have filaria. So diagnostic is becoming a nightmare in this kind of context. And then also, because the situation is moving forward, MSF we had to adapt our strategy. Before it was a lot based on health facility, health structure based. But now we have to go, because of conflict, because of also the tendency of moving forward, task shifting, moving on decentralization, moving on integration of services, and the most important, it's moving also toward the community-based approach model. How do we tackle diagnostic in MSF? I think this picture represents a bit what we say. It's investment in diagnostic tool to our own reflection is following a vertical approach, which is project based on disease specific. At the end, this is the daily life of a community health worker, of a midwife working in a health center, that all the disease or all the diagnostic problems are solved by having only rapid tests, where you can find, sometimes they have to do 2, 3, 4, and then on the top of this, linking with HIV, linking with all, even tuberculosis, they have also to use how many machines and everything. And the end user often say, they often say, sorry, I'm lost. I don't remember which one is for the HAT. So I think it really brings us to think that this vertical disease focus approach might not be what we need in the future, and maybe we should first change our way of thinking, and then to boost the development, find better scenarios. And then we say, well, maybe it's our own interest, no, to say we have vertical, but we start looking also at how the others outside of NGOs and specifically MSF are tackling. And here we still see a vertical approach, disease focus, and even more, you have the group of people working exclusively on developing tools for reference laboratories, and then you have the extremists like MSF always want to go for point of care, and was mentioned by Rosanna, I want a rapid test for everything, thermostable, highly sensitive, highly specific. Then the question is, where and who take those opportunities in the middle? You know, reference laboratory, they're often only in capital, not often accessible, but then what do we do to equip a district laboratory, for example? There are very, very few things popping up. So the use of point-of-care diagnostic in general are clearly justified in unstable context or when population is difficult to reach, but then a combination of lab-based and point-of-care diagnostic might be more adapted in stable context, which is at the end the majority of the context where we are working. Should the approach then be more on health system strengthening? What does it mean? And it was explained very well by Rosanna. You have so many diseases at so many levels that you can have point of care for certain facility, and you can move up to the central level and have other kind of tools. What does it mean also? Process optimization, health system strengthening. Beside the development of the technology itself, we can see connectivity have a role. But then my question is, if we have only, or if we want only very good machines based in a reference laboratory, then who is working on this outside laboratory niche? Which is at the end the drone issue, which is who is today working, for example, on tools or tubes with stabilizer that will allow tools to transport, to detect. So there is, I think, a need of taking this overview of the global aspects of what strengthening health systems means. The other question we had, and it's going in the same line, it's because we have this vertical approach, does multi-disease platform is something valuable? And we have a lot of internal discussion, and we see that multi-disease platform have the potential to simplify the use on the field, simplify as well the procurement. It's not the same to have three. Today you need a machine for CD4, a machine for viral load. It's a bit from the experience of the gene expert, but gene expert is on the top one technology and one company. So procurement will be much simpler for health system and for the Ministry of Health if they have to maintain only one machine and not 20 machines. It might be more cost effective. And what is important, it will play anyway an important role today given the burden of the co-infection. It's HIV and TB is well known, but I think the experience we have the past 2 years in South Sudan, mixing and playing with NTDs, it's also very important because co-infection is quite high. And on the top of this, it's sometimes have a potential to push for abundant prices with manufacturer to achieve higher volume and consequently as well reduce the costs. The optimal idea, this is our dream for the following 10 years and hope to have it. I think what we are dreaming of, it's not only an open source platform, but an open source multi-technology that can combine in the same molecular testing and immunoassay, whatever is the combination, and then that's everybody can develop the cartridge of interest. We have a lot of discussion around the fever, specifically fever outbreak, but NTD have totally the space to fit in this kind of setting. Then, before dreaming, we need to go a step back and to see what is the chain and what is the pathway to develop diagnostic. And it's true that inside of MSF, we often focus our energy to do the field validation because it's also where we are very close to the patient, so it's easy. But then we clearly think that the first upstream is something important and at the end something that is often neglected. How many target product profile have been published, have been clearly discussed? How many needs market assessment have been developed? Very few, and even very few for the most common disease, and even less for the NTDs in specifically. And going closer to this point, obstacles we identify, it's clearly the market analysis. It's very important for a manufacturer, or each time you contact a manufacturer, the first reaction it's, yeah, how many people? And how, and this is where, I mean, especially in MSF, we look to each other to say, we have a lot on our field, but what does it mean? So I think there is a need also to have more session and more strengthening a bit the arguments on this issue. Product profile. I haven't seen, for example, a clear target product profile for neglected disease. There are many on Chagas, and it's not only one is published, the next year is another one is published, and it's exactly the same, but there are several publications. But for brucellosis, even for dengue, it's not clear what do we want and what do we need, and target product profile can for sure help in this way. And then when somebody starts to develop the other blockage that we saw it in the Ebola outbreak, it's where do I find the sample to test my prototype if I don't have access directly to the patient? And there are a clear missing serum bank. I mean, the initiative that WHO had several years ago of building a biobank, a serum bank, well, a biobank, because it's include urine and etc. for sleeping sickness, will also secure that manufacturer can have access for the first step of validation of a product. And then, so this is crucial. And at the end point, because in the middle, there are less difficulties. NTDs, the most difficult part, is to find places where you have patients in order to test. I mean, HAT today, you have to test, even in Congo, sometimes 20,000 patients to find 100 positive. Well, but more globally, it's not that much a problem. And then after, at the end point, it's always the distribution network and for machine the maintenance network. So when you see, we start to identify that clearly there are some gaps in the upstream, and those gaps have a direct consequence, which is diagnostic tools are not coming out, let's say. And then we think maybe we are the only one. So I'm very happy today to see the presentation of Rosanna, because we are not alone, but also by doing a very, very rapid mapping, we see that there is at least 46 agencies that today are speaking about we need better diagnostic tools. So this is good because we are not alone. But then what is missing? Directly, the coordination is missing, the collaboration is missing, the sharing platforms are missing. So in order to conclude, I think we need, or in MSF in general, we think we need to have a broader approach, not only focusing on technology and the development, but also in terms of health system strengthening. We have to improve the definition and visibility of needs, define short, medium, long-term investment, because is really in 10 years PCR, would it be really the top optimum platforms? What are we going to do with all these PCR generated platform in 5 to 6 years? Nobody have a clue. So partnership is crucial to tackle so many problems in the diagnostic development. Communication and coordination between all actors is the must. Thanks a lot.